total joint replacement surgery is the solution for debilitating joint pain when non-surgical treatments no longer work.
If you are in that predicament, don't miss this week's informative edition of Health Talk. Eric and I are up next. Hello, I'm Dr. Vicki Smeetak.
And I'm Dr. Eric Mazer. Today we will discuss joint replacement surgery. Our guests are Dr. Mark Fletcher and Dr. Nicholas Polifroni. They're both orthopedic surgeons with Coastal Orthopedics and part of the new Joint Replacement Center. It's not that new anymore at Norwalk Hospital. So welcome back.
Thank you very much.
Yeah,
it's been open about over 2 years now.
Yeah, that's it's fabulous. Because before I retired, that was it had opened, and we'd had, I guess, the initial year experience. So let's talk a little bit about joint replacement surgery. Why do people get to a point where they need joint replacement surgery? What's going on that creates that problem? Nick?
Well, osteoarthritis is probably the most common thing, the wear and tear joints. The joint that degenerates to a point where the articular cartilage that gives us our cushions on each side of our joint wears out. Whether from injury, trauma, genetics, we all think that probably most of it is genetically driven. But the articular cartilage has a fine lifespan, and once it starts to deteriorate, it starts decreasing its ability to cushion the body. The body has nerve endings that tells you something's wrong. The joint gets stiff, it gets painful, it gets swollen, and people have difficulty with their mobility and their ability to
It's sort of depressing, Mark. It makes it, we're really a machine. Now, it's a pretty basic idea, is that you've got something that moves against something else and it wears out.
So patients come to see you when they've really looked at other options or maybe have tried to do physical therapy or things like that, and then finally they say, help, I can't move the way I used to, I'm having a lot of pain. Is that pretty typical, or?
Yeah, I think a lot of people just come in for pain. They don't know why. And you know, if x-rays show that their joint has deteriorated and they do have arthritis, that's when we start talking about what can you do for it. You know, easy things, you know, like weight loss, you know, activity modifications. Maybe you're a runner, maybe you should be a biker. You know, trying to figure out how to work with it. You know, it's the situation, if you use a metaphor like a car tire, if you wear away the tread, it's still a tire that can work, but maybe it's not as good as it used to be. So you try to work with what you have. And if you get to the point where that no longer works, then something like a joint replacement can be very beneficial.
Now, I know that doctors and scientists have been working for years trying to find ways to replace the fluid or replace the cartilage or make it grow back. Where do we stand with all of that?
It's a common problem that we haven't solved. The articular cartilage, our main construct of our joints, is the one thing in our body that doesn't heal. It doesn't heal very well. So we've initiated treatments where we stimulate the cartilage with microfracture, drillings. We've tried to inject gels, or what people have heard about, rooster juice or chicken juice, chicken soup. But so far, nothing really makes the cartilage
So chicken soup does not
grow.
work for this?
It helped. No, chicken soup. We call the injection material chicken soup because it comes from roosters, right?
And
chicken
is that
soup
because
works.
that cartilage, the articular cartilage, sees so much movement and wear and tear over time? Is that why, or do we know why that cartilage doesn't heal as well as others?
No, we don't.
Well,
we break our bones and they heal.
Right. Part of it is there's not a whole lot of blood supply to those areas. You know, they receive their nutrients from diffusion from the joint. Now, a lot of it, look, you know, the people doing the research for it, the joint itself changes over time. So its ability to support itself changes too. So really, there's a lot of very kind of complex things going on here, but we see it kind of as the end part of it, which is, you know, arthritis, things breaking down.
And once the joint becomes improperly aligned, I presume it wears out even more quickly. You know, like malaligned tires.
Right. Well, injuries, old injuries, prior surgery, prior injuries to the joint, which makes the joint a little bit different than it used to be, makes a big difference.
So today I think we really want to focus on the surgery, and which has really come in an extraordinary way. We were talking before the show about the time in the hospital and the rate of how quickly people rehabilitate. Give us some sense of what is modern joint replacement surgery. Now, I know you do hips and knees, but you focus mainly on hips.
Yes.
You do both.
Yep, that's correct.
So tell us, you know, what has changed?
Well, what's changed is largely the rehabilitation, but all components have changed. Our surgical approaches have changed. We're doing minimally invasive surgery is really a misnomer. We're doing smaller incisions, less muscle damage, less joint trauma. We're utilizing smaller instruments. The components have evolved to be more natural, more anatomic, so they function better. The materials, as we talked about before the show, are almost indestructible now, so we can offer patients longevity. So if you have a patient who's in his 30s or 40s or 50s, before we used to tell them they couldn't have a joint replacement, now we can offer it to them.
And they couldn't before because the joint would wear out
The joint
too
would wear
quickly?
out, the materials would wear out, and they'd have to have replacement after replacement.
So
But
how long do these materials last now, just out of curiosity? You can
it-
have a
it
joint
dep-
that
it
can last
depends.
you,
It could last 25, 30 years. And we go by
Wow.
percentages. So now we talk about 80 to 90% of patients will get 20 to 25 years out of even their hip or knee replacements.
Not to
that's
be
pretty impressive.
facetious, not to be joking, but if you have an older patient who is 75 or 80, do you use a less expensive, cheaper joint replacement so that because they're not going to need 30 years?
Yeah,
Now we'll
that's a
hear
great
the
question.
backstory.
There's actually several different, at least in hip replacements, there's several different ways you can construct the bearing. A standard kind of gold standard total hip was a metal component, a ball against a high density plastic socket. That one, if you look at those studies from even 20 years ago, 91, 92% of patients went 20 years or more.
Right.
It's conventional, we know how it works, we know how it lasts, and in an older patient who's not really looking for high intensity
use,
exercise, high use, that is still a fantastic component.
So it's not just how long they're going to live, it's also how they plan
Well,
to
physiologic
use their joints
age,
after the
right.
replacement.
But what also has changed is the rehab.
Yeah.
And a lot of it is just us wrapping our heads around, okay, do we need to keep patients in bed for a couple of days after surgery? And it's a push all over the country to get patients out of bed the same night of surgery, in the hall the next day, and many of our patients are going home in 48 hours.
How do we do that, Nick? It hurts to have a joint replacement, right?
We've
So how do we
modified
do
the
that?
pain management, and that's not just us. It's a movement all across the country and the world. We've stopped using intravenous narcotics. We use a procedure called multimodal analgesia, which takes a lot of different medications in smaller doses, so nobody gets sedated.
Okay.
And our patients are bright and alert.
So it
and
takes the
they're in
pain
control.
away, but they're
Takes
still
the pain
able
away,
to
but
get up
without
and-
the side effects of
But for
narcotics.
these are not new drugs. It's just it's using them in new ways.
Exactly.
Right.
And a lot of
Exactly.
the problems with all these medications previously is that, the surgery itself wouldn't keep you in bed. The side effects of the pain medications we were using, like just using narcotics alone, nausea, constipation, dizziness, higher risks of fall, those would keep people in bed. So we've kind of decreased our reliance just on that medication or those medications and used other pain
Yeah, I simply remember
medications.
my own training where we
Yeah.
were basically trained to use one narcotic and
Right.
maybe something like aspirin or Tylenol
Right.
along with it, and then just keep pushing
Right.
that narcotic up to the point
And a
we
lot
got
of-
pain relief.
Yeah, a lot of the change has been preemptive analgesia, so getting people pain medication on board before
Ahead of
the
time. Even before
surgery
surgery.
happens. And that actually keeps the systems, the pain pathways in the body, it keeps them from getting overwhelmed and spinning out of control, so we don't have to chase it later.
That's a great approach.
Yeah.
And now I do want to go back to the joint. We have a video that actually illustrates some of the modern joint replacement technology that's available, and then maybe after we take a look at this. So Nick, Mark, tell us what we're looking at here.
So
Well,
this, go ahead.
Mark, go ahead.
Oh, this is standard joint replacement. So you have a polyethylene socket and a ball. And
actually the
well, actually, this is actually one of the more modern ones. There's a big, large plastic rotating ball that allows a lot of range of motion, actually near normal range of motion.
So you have to cut out parts of the socket and the ball of the normal hip, or all of it, in order to replace it with this device?
I think when I think about it, I think of more of a resurfacing. We just enlarge the normal socket to accept a round implant, and then we just sort of you take the femoral head away, but you're not taking the whole femur away. You're just making a slot, and you're using good carpentry to put a press fit instrument into there. This
What
is
holds
a
it in
standard
there?
total hip.
Do you glue it in, or does it?
It's press fit largely. We do use a bone cement sometimes, but the trend these days is to just use what we call press fit. And the components actually have a fretted surface, so the bone grows in and it locks in place. This is showing. This is
This
the
one
newer
looks a
model
little
showing
different.
an increased range of motion. This just shows how the equipment and the materials we use keep getting better and better and better.
Is this one of the newer?
It's one of the newer ones, a new
So-
application.
So there are really 3 moving parts, or you have
There are
these-
actually 2 moving parts, but there are 4 pieces of that, 5 pieces of that component.
So how do these differ from the original joint replacements that we used 20 years ago?
Not a lot.
Yeah, the structure is basically the same.
Right.
The materials are better.
The
Mainly
materials-
that plastic, that white coating that is shown there is, it used to have a certain longevity. It was made simple medical grade plastic, polyethylene. Then they found ways to make it better by pressing it and forging it almost to make the molecules melt together. And then about 20 years ago, they found that if they irradiated the plastic, it was even harder. And then some smart engineers needed better plastic. We asked them for better plastic, and they found if they irradiate it 3 times, the stuff is almost as
It's not
hard.
radioactive when you put it
No,
in.
No,
no,
no.
no. But it becomes almost as hard as ceramic.
So
Yeah.
as a non-orthopedist, looking at the 3 different videos, I'm imagining that the third one would give you probably the best mobility, so that would be reserved maybe for somebody who has a more active lifestyle, or is that not true?
More active
how do you
lifestyle, or
decide?
someone who we're concerned may have a very small frame, so we can't use more anatomic, a larger anatomic joint, so we would put this in. Somebody
Okay.
may have had a previous hip surgery that was dislocating.
And we're worried about
In the
it.
revision, we worry about a revision, we would go revise and put in this dual mobility component that would be less dislocatable and be better for their function.
What kind of quality of life can patients expect after having a total hip replacement? Somebody who was relatively active, do they go back to a similar lifestyle as
This-
they were used to?
The one thing about hip replacements, which has been true for a long time, is actually one of the most successful orthopedic interventions we've done. People have returned to an excellent quality of life. You know, we asked them not to do high intensity impact exercises like running, but everything else is open
Is
for
it
discussion.
concern that they'll break the prostheses?
Well,
or-
it's increasing your wear rate, and over time, you know, just like any just like the normal joint, there's a certain longevity. We don't want the joint to wear out so soon. We want them to have as long active lifestyles they could get it, but we try to avoid the high intensity ones to avoid unnecessarily high wear.
Right.
The materials don't break anymore.
Yeah,
The alloys are so strong. I used to see that early on, 25, 30 years ago.
But now you
They
don't
would-
see that.
No, they don't break anymore.
The bones will break before
Yeah.
they yeah.
Exactly.
That's all we have time for this segment. I think when we come back, we want to talk, we're going to keep Mark here and bring in Dr. Lynch
Okay.
to talk a little bit more about this remarkable change in post-operative management, which I've been astounded by, frankly, the rapid rehabilitation. Which,
Rapid recovery, yeah.
It's just extraordinary how people are discharged from the hospital to home. So we're going to hear about this in the next segment, and we'll be back after this short break. Hi, Vicki and I are back with Dr. Mark Fletcher and our new guest, Dr. Michael Lynch, both orthopedic surgeons with Coastal Orthopedics. Mike, welcome to the show.
Thank you.
Welcome.
Nice to be back.
And Mike, you do hips, but you mostly do knee replacements. Tell us what are the main differences in recovery between a knee replacement and a hip replacement? Are there any?
Well, we have made great advances in controlling the pain. Unfortunately, knees hurt more.
They do hurt.
It has to do with the nerve supply and the type of muscles that we have to push around. So hips, there's a window for us to get a hip in that's a little less traumatic. Knees take a big hit when we put the knee in, so they're more painful. But as Nick was talking about in the previous segment, we made tremendous gains in being able to control that pain, and the rehab is dramatically different than when I was a resident.
Let's talk a little bit more about that, because I think you were saying before the show the average hospitalization for a knee was 4 or 5 weeks in the distant past, and now it's a couple days. It's amazingly dramatic. What's going on, Mark?
Well, I think, well, it's a lot of different things. You know, a lot of it is just sort of the progression of technology and our ability to do it. I mean, you know, many years ago, they didn't know how to do it, so they said, well, we should immobilize these people. And then you realize over time they do better moving them, and then pain becomes an issue. You can only move someone as well as they can tolerate.
Right.
And so over time...
So you don't want to rest that joint after.
No, I
You
mean,
let-
it makes it stiffer, it makes it harder to get back to normal function. So we found that early motion is much better for these types of procedures, but you've got to, that's great to say, but if someone is really painful, they're going to say, I can't do it. So you've got to give them the help they need to get through the rehab, and so that's when the pain pain control's been
Nick
excellent.
mentioned that it's really a mixture of a variety of different drugs. Can you be a little bit more specific about how you achieve this dramatic pain relief? I've seen it. I can't
Yeah.
believe post-operatively people are not in agony. They're fine.
Well, there's a narcotic involved. We still use that, but no more injectables or intravenous. It's all oral narcotics. Some of them are a little bit more long-acting, so they can be time-released, and that helps give us the cover Mark referred to earlier by giving it ahead of time. There's a nerve-active medicine, really an anti-seizure medicine, but what it does is quiet nerves, and this helps to control those pathways, so it's also having an effect. We use anti-inflammatory medicine. We're all familiar with over-the-counter anti-inflammatory medicines. Some of them are not good because we're also anticoagulating the patients because of risk of blood clots. So some of them are amenable to that, so we add the anti-inflammatory. And we use some steroids occasionally, which also help to bring down
These
swelling.
aren't the anabolic steroids
No.
that the baseball
Yeah.
players use.
Right.
There's prednisone or
Anti-inflammatory.
cortisone-like steroids.
And even lowly Tylenol. You know,
Could you just mention that, because that one blew
Right.
me away too.
Yeah, well, they use Tylenol orally, but also intravenously, and it's actually a really good, what we call central pain control. It actually works deep in the midbrain where all these signals are coming through.
So it
it's
works
just
better
another way
than
of-
oral Tylenol.
Yeah,
Yeah.
and so we
Yeah.
give that around the time of surgery, but
It-
what it
it's-
does is turns the volume down on pain, even though it's just, Tylenol, you get it from the drugstore, but in the setting of all this other stuff.
Without sedation. Like the
sedation.
narcotics
Yeah.
often give you sedation,
Well-
constipation, nausea. Do you get
Yeah.
any of that with IV Tylenol?
No, you really don't.
That's
that
really a
really
big
blew me away,
advance.
because
Yeah.
I firstly heard about IV Tylenol from you guys talking about how you wanted to use it in the joint
Yeah.
replacement, and it's really quite remarkable that such a common drug, given a different way, can be so effective.
Now, a typical patient, Mike, who will have a knee replacement in the morning, let's say, are they walking by later that day, that very same day? What happens to them afterwards?
Yes, they get up and walk that evening. Oftentimes up and down the hall, but at least to get up to go to the bathroom. And some of that, the last one we didn't mention is what lay people refer to as Novocaine, but the local anesthetic. So
Yes,
we put-
that's really changed too. Say a few words about that, because I
So
think
we-
that's a fabulous thing.
So we finally learned that we do these a lot of the times under regional anesthesia where the patient is insensate from the waist down, so they don't feel anything. Then at the end of the case, we would put a local anesthesia in there, but our best ones lasted 1 to 8 hours. And that took care of that immediate post-op pain, but there's a new development in that where this medicine can now last up to 36 hours or longer. And we have some peripheral blocks that the anesthesiologist can do where they put local medicine into a nerve supplying a whole area, yet you can still use your muscles and function. So that is what gets us through that really tough first couple of days.
Any side effects, any downside to doing that the patient might experience?
Very few. Those local anesthetics are all very safe. So each of these medicines has a panel of side effects, and you have to be careful. But we made the point earlier that we're able to use a lot lower doses of all of them,
Right.
so that we're not into
Right.
that side effect range by using the multimodal approach.
And it's
Yeah.
really interesting. You're blocking multiple
Yeah.
different pathways
At the same time?
at the same time.
And usually, and what kept people in bed were side effects of these medications we're given to prevent pain. So if you can decrease any one medication by spreading them out, you're taking them out of bed because they're not being affected by the medications.
Right.
So that then leads to the next remarkable innovation, which is early physical therapy.
Yeah.
So why is that important?
Well, you're operating on a joint. It's surrounded by muscle, and we've learned, the kind of the history of orthopedics. If you put someone on a cast or you tell them to not walk on things, they lose bone density, they lose muscular strength, their joint gets stiff. We don't want any of that to happen. We want people to walk normally, want them to return to their lifestyle, and so if you can get those things back on board, motion, walking, strength, if you can get those back into the system or into the program early on, it allows you to heal faster, it allows you to heal with less scarring. Your joint range of motion returns to more normal, you don't lose as much strength, and so your ability to get back to functioning or functional, which is really the name of the game, when can I get back doing this? It really minimized it, and I think that's been quite striking.
And early physical therapy, as early as the same day,
Yeah.
the next day?
Correct.
And can you give me a sense of what you have people doing? You said the first night, usually at least walking in the bathroom, maybe walking in the hall. Of the first few days in the hospital, how far do people get?
You look for motivational things because some people, when they're hurting, it's tough. So we actually have a chart on the Joint Center, and each patient's number is there, and they log the number of feet that they walk so that it gets in to be a little bit
Any
of how
prizes for the
Well,
walk?
extra cookies with dinner. But early discharge, and so you're doing well, you're motivated. It's really across all of orthopedics. I mean, when I was training, we were coming out of the tail end of cast and rest and immobilize everything, and that was standard practice.
Right.
So I often say, I don't know what we're doing today that 30 years from now we will be doing completely differently.
Well, to follow that thread then, do you see this ever becoming, or in the not too distant future, becoming an outpatient procedure? If we're minimizing, we went from multiple weeks in the hospital to 2 days in the hospital, maybe an overnight stay. Are we going to get to a point where these are going to be, you go in the morning and you have it done, and then you go home and you get physical therapy the next day, or is that probably not likely to happen?
It's happening.
Yeah.
It is
It's
happening.
already, we've come to that.
We
It's
have.
already here.
Yeah.
And how do those patients do, as opposed to, do we have any studies yet that look at one versus the other?
It's a
As-
select group of patients, and so your studies are going to be biased because you're picking the absolute best specimen that
The
you
Highly
can think of
motivated.
Right.
to pull that off. So their numbers are going to be, but the early numbers are encouraging. It takes a fair amount of organization and getting the visiting nurse to be at the house to set up things at the same time. So it's complex, but it can be done.
Is this patient-driven mostly, you would say, patients who really don't want to be in the hospital, or is it insurance-driven, or a combination
Well,
of
everything.
both?
Combination of
Yeah.
all that stuff.
Right.
Yeah.
Everybody's trying to do things as efficiently as possible, and that's the most efficient.
Right?
Yeah.
But we're making sure it's the safest.
So looking at the average patient and maybe the best patient who gets a total knee or a knee replacement, how quickly do they get back to normal function? Maybe not completely asymptomatic, but are we talking about 6 months, 2 months, 2 weeks?
I think if you look at it from a healing perspective, it takes about 4 to 6 weeks for soft tissues to heal enough to tolerate increased load or increased activity. So if you want someone to just walk around and feel good, maybe 3 to 6 weeks out, they get away from using a cane or a crutch for protection and start moving more normally. For someone to get back into sports, you've got to have some component of strength recovery. And so just like you're recovering from an injury, maybe 6 weeks you're feeling good, you're walking around, but for you to get back to what you want to do and do it well, you're talking more like 3 or 4 months. And that's following biology. It's not specific
There's
for
nothing we can do to
But
speed
I've
that.
seen people who are just very tough-minded, and they come in 2 weeks and they're walking without anything, regardless of whether I want them to or not, and they're doing it. So I would say I've seen much faster, but those are unique individuals. If you're looking at general, I think 4 to 6 weeks, and then
On that
slowly
happy
increasing.
note, we have to break. It's really fabulous. So people can look at this and get tremendous relief with a few-week investment. And
Right.
it doesn't sound like that much pain. So when we come back, we'll have a question for today. We'll keep our guests on the set to help us answer that question.
But right now, let's take a look at some of our upcoming events sponsored by Western Connecticut Health Network. This week's viewer question is, when is the right time to undergo joint replacement surgery?
And we have two experts on the set who do this. When is the right time to undergo joint replacement surgery?
I think it's still a surgery. So I think it represents the last step in treatment of someone's pain or arthritis. So, the typical things we ask people to go through is, maximizing their own health. Weight loss plays a big role. More weight on the leg or the knee or the hip actually increases pain. So simple things like even 10 pounds of weight loss can make a significant
simple 10
difference.
pounds. Said by a skinny man.
Yeah, that's right. No, but it's important, and we live in a society where there's a lot. We tend to be bigger, and so I think it's important to put out there. But other non-operative treatments like physical therapy, improving a range of motion, activity modifications, oral medications can be tried, even injections. But if you get to the point where non-operative treatment no longer works, and you simply are having too much pain on a daily basis to live life and to your activity of life is being affected, then I think that's an appropriate place to start thinking about
You
it.
factor in what the patient wants to do. Somebody who wants to be more active, who could probably be sustained in a less active lifestyle, but they want to hike or swim or whatever.
I do that by example. So the person I have trouble making happy after joint replacement is the guy who wants to walk 36 holes of golf but could only walk 18 and before his knee starts aching him. To take that guy, his improvement is narrow compared to the stiffness and soreness and unpleasantness of going through knee replacement. Give me the person who's given up golf or has gone to riding a cart and can't, then that's it. So to me, it's when you notice that you're missing significant things in your life, and you have to ask patients carefully because it's like the frog in the hot water. If it's slowly turned the heat up, they've slowly been letting go of things, and now they realize they're not doing much of anything they were doing 5 years ago.
Yeah.
So you have to look at that carefully.
And again, a healthy lifestyle never hurts, whether it's
It helps
before
everything.
surgery or after surgery.
So stay thin. Okay, thank you, gentlemen. If you have a question you'd like to ask Vicki and me on Health Talk, please contact us at healthtalk@norwalkhealth.org.
Eric and I would like to thank our guests today, Dr. Michael Lynch, Dr. Nicholas Polifroni, and Dr. Mark Fletcher for coming on Health Talk today.
Vicki and I will see you next week on Health Talk.